Okay. So there's different types of shock under distributive shock. There is, well, and so the first one we're going to look at is anaphylactic. We're going to look at neurogenic, anaphylactic, and septic shock. Those are all distributive shocks. The reason they're called distributed is because it's distributed throughout your body as well. Anaphylactic shock, very straightforward. It's an overreactive reaction to an antigen, antibody reaction, so your body has an extreme allergic reaction to it as well. I thought this is an interesting slide. That here are the frequency of events. Penicillin is 5 to 1%, bee stings, and contrast media. So how many deaths a year? Not that many, but we see a lot of, like, you see in the ER where people carry EpiPens now, right? That kind of a thing for the reaction as well. So what happens with these people? They turn bright red. They have itching. They can have hives with that as well. A big belly, nausea, vomiting, and the diarrhea. And this is the big one, is they get that very tight vasoconstriction, and so they can't exchange air, which is the number one thing we're worried about in anaphylactic reaction. And the first thing we treat is airway, A for airway, right? First thing we look at is well. Their heart goes fast, they can be dizzy from that, and they can be hypotensive from the low, they can be syncopal from the low blood pressure. Cardiovascular collapse, don't worry too much about hemodynamics as well. Rule out all these other things, don't memorize this, it's pretty straightforward. The goal is to stop the allergic reaction. The first thing is airway management. The second thing is circulatory support. So, we give them epi right away. So, which is going to make them more tachycardic and more hypotensive, and they're going to vomit more, but it works. So that's a good thing as well. Norepinephrine and dopamine if the blood pressure fails, and we're going to try to block the histamine release with dexandramine, and then ranitidine, which also has a secondary effect. Although it works on the gut, it also has an antihistamine effect as well. All right, so neurogenic shock. You have a broken spinal cord, or you have a broken neurological feedback system. So you have this massive vasodilation that happens, and your body can't tell the brain to stop making it happen because it's broken. The communication from the vasodilated vasculature doesn't reach back to the brain, so it doesn't fix itself. It doesn't get better. So spinal cord injury being the most common one. I've never heard of or seen any of these. Possibly if I worked in the OR, I would have seen it from spinal anesthesia. I get it. The idea is that you're, again, blocking the pathway back to the brain. I just have never seen it, so I think we'll just mostly say it's a spinal cord injury. I think I'm going to tell you the T level. You don't need to memorize it, but it's in my notes. We're doing so good. Above T1. So in order for this to happen, it has to be above T1. So mid-thoracic or above as well. Yeah, that's enough on that. So usually it's the trauma, someone breaks their neck or breaks their back, and they get hypotensive. It's just that distributive shock. It's that huge vasodilation, so they have hypotension with it as well. And above where the problem is in the spinal cord, they're going to have warmth, and below they're going to have cooling as well. They're going to have venous pooling from all the vasodilation. Don't worry about the hemodynamics as well. So what we want to do is change their vascular tone, improve the cardiac output, and airway protection. So they have that vasodilation. We're going to try to fix that. We're going to give them norepi. We're going to give them dopamine. We're going to give them vasopressin. Whatever we need to give them to clamp down that vascular bed and fix the problem as well. And then what we're going to do is we're going to whip them off the surgery and try to fix that part that's broken, because usually it's broken and it's sticking out, the spinal cord's sticking out, so that's what the problem is. So they need to go in and, stabilize the fracture, kind of a thing. So yeah, don't worry about this chart as well. Which one is this? Oh yeah, we need to watch both of these. These are going to be about sepsis 3. They take a couple of minutes. Maybe we'll come back to it. Well, we're getting close. We're doing okay. Sorry. I just think he explains it so well. So let's do this one and then we'll see.
If you're like me, you spend a lot of time online, and so you've probably seen there's a lot of buzz going on in regards to sepsis. You see, here lately, the terminology we use to define sepsis has changed. This came on the heels of a paper that was published in the Journal of the American Medical Association. This paper is the result of a consensus panel of experts that came together. They looked at 92 different systematic reviews and meta-analyses. They used the Delphi process and came to the conclusion that we need to change the way we talk about sepsis. We need to change our approach if we want to A, have a better predictive indicator of sepsis mortality, and B, impact changes on survivability on our patients. After these publications were made, 31 international societies have endorsed them, including the American Thoracic Society. This is the third time the definitions have changed for sepsis. The first was in 1993, then in 2002, and now 2016. Because it's the third time, most people are calling this sepsis 3. Let's go ahead and take a closer look at sepsis 3. Basically, we now think about sepsis as organ failures stemming from a dysregulated host response to infection. We've learned a lot in the last several years about sepsis through study. For example, we see sepsis as a balance between inflammatory and anti-inflammatory signaling, between the innate and adaptive immune response. And then we know things like apoptosis, oxidative metabolism, and an individual's kinetic response are all at play. So let's take a look at the old definition. Traditionally, we've thought of sepsis as a cascade, but things have changed. We've now eliminated the term SIRS, and that's because so many things can cause inflammation of the body that don't have to do with infection, and we want to be really intentional now with the host response to infection. We've also deleted the term severe sepsis because we thought it was really redundant. Severe sepsis and septic shock both involve organ failures. The term that's come in to replace the term SIRS is now QSOFA. So you might be wondering, what is this QSOFA? Well, here's the sofa. What do y'all think of it? Oh, hey Amber, what's up?
Not much. I'm just checking out this new sofa you got here.
Yeah, it's pretty sweet. What do you think?
I like it. In fact, it's pretty comfortable. So much so, I've seen the residents hop up on it. In fact, they like it. Comfortable, simple, easy to use. You need 3 things. Now they know you need a GCS less than 15, a systolic less than 100, and a respiratory rate greater than 22.
Exactly. And if you have 2 out of 3 of these in a patient with a known or suspected infection, you're worried about
sepsis. Simple as that. I think that's all.
That's it.
I'm out of here.
Later.
Bye.
Now that we've learned all about the QSOFA, let's talk about the changes to the term septic shock. I find them easy to remember because there's 3 changes, and this whole thing is called sepsis 3. The first is that your patient is requiring vasopressors to keep their mean arterial pressure greater than 65. The second is that their serum lactate level is greater than 2. And finally, we want to make sure that the cause of their shock is not from hypovolemia. If your patient meets all 3 of these criteria, they meet the definition for septic shock, provided they have an infection as their source. So we can now say goodbye to the terms SIRS and severe sepsis. Amber, would you join me? We're going to take a moment of silence for SIRS and severe sepsis.
Cheer up, Graham. There's good news. In fact, things are getting better. You know why? JAMA published a new article. In fact, there's an algorithm to help you in the management of sepsis.
Yeah, I've heard of that algorithm. In fact, let's take a look at it right now. In front of me, we have our sepsis algorithm. As we look at the top, you can see it begins with the QSOFA score you've been hearing about. Rolling down, if the patient's QSOFA score is positive on screen, now we need to be looking for signs of organ dysfunction. You can use the standard SOFA score to look for this. And if there's an increase of 2 from baseline, now we're really worried about sepsis and end organ damage. Rolling up again to the bottom of our algorithm, we see at this point we need to intervene. We're going to be using IV fluids and vasopressors if needed to keep the MAP greater than 65 and checking a lactate level. If the lactate level is greater than 2 and vasopressors are needed, then we have diagnosed septic shock. Septic shock carries up to a 40% mortality rate in hospitalized patients. So all these measures we're talking about today are done to try to avoid septic shock. All right, so in conclusion, what have we learned? Well, first, we're no longer using the term SIRS. It's too nonspecific, and we're substituting Qsopha. So if you have a patient in the hospital with positive infection or you suspect an infection, you want to apply the Qsopha screen. If it's greater than 2, well, we need to think about organ failures and escalating care. This might involve moving them to a critical care unit, starting antibiotics, or giving them more IV fluids. We've also talked about the new definition of septic shock. We said that lactate is now greater than 2, vasopressors to keep MAP greater than 65, and we have to rule out hypovolemia as the cause of shock. I'm glad you tuned in today. Thank you for watching. See you next time.